Hi, my name is Tim Garvey, and I'm very happy to talk about the new AACE comprehensive clinical practice guidelines for the medical care of patients with obesity. We're very excited about these guidelines. We are hopeful that this will really have an impact and provide a rational model of care to improve outcomes for patients with the disease of obesity. There are a number of algorithms and guidelines that are in existence. I think they've created a little confusion among primary care healthcare professionals. Some of them are not evidence-based, as our algorithm in obesity, the AACE algorithm, which was part of the diabetes algorithm, was not evidence-based, is more expert opinion. But some like that are not evidence-based. Some are confined to questions around which only randomized clinical trial data exists, which is not all of the things that a clinician has to address when taking care of a patient with obesity. So you end up with a piecemeal set of recommendations that isn't readily translatable to real-world care. So we undertook a process of evidence-based development of guidelines that are comprehensive, that address all steps that a physician or healthcare professional has to undertake to treat a patient with obesity, including screening, diagnosis, evaluation, therapeutic decisions, treatment goals, follow-up, etc. We devised a set of questions around all of these steps of care. We then examined the evidence, the best level of evidence to each of these questions, and developed 123 evidence-based recommendations that address all aspects of obesity care. From these evidence-based recommendations, we translated them into an algorithm and as well a chronic care model that involves an activated patient and a prepared practice that can use these guidelines to the best advantage for patients. And of course, that has to sit within a larger construct, our healthcare system and even society at large. We need concerted action to really combat the disease of obesity and the increasing suffering and social cost of this disease. Now, our guidelines call for two components to the diagnosis. The first is an anthropometric measure to determine whether you have excess adiposity or not. We use BMI for that, and we continue to recommend the use of BMI, but it's important to recognize that high muscularity or edematous states can alter the BMI independent of fat mass. So you need to clinically evaluate a BMI number to make sure it represents excess adiposity. The second component of diagnosis is the degree to which that excess adiposity adversely affects the health of the patient, which we take to mean the risk, presence, and severity of weight-related complications, such as metabolic syndrome, prediabetes, type 2 diabetes, dyslipidemia, hypertension, non-alcoholic fatty liver disease. All of these things are in the cardiometabolic disease nexus of complications. In addition, there's biomechanical complications, those that are due to just carrying around an increased body mass. Important complications such as obstructive sleep apnea, osteoarthritis, GERD, urinary stress incontinence, etc. So it's important to evaluate all patients for the presence or absence of these complications and to incorporate that into the clinical component of diagnosis. Then you make your therapeutic decision based on the degree of weight loss it would require to, in essence, improve the patient's health by preventing or ameliorating these weight-related complications. There is a dose response between the amount of weight loss you need to lose and improve various complications, so you need to take that into account. A structured lifestyle intervention that involves a healthy meal plan, whether it's low-fat, low-carb, Mediterranean, DASH, vegetarian, a macronutrient mix that provides foods that are compatible with the patient's personal and cultural preferences, but delivered in a reduced calorie format. An increased physical activity prescription involving activities that the patient enjoys, as well as a number of behavioral interventions that, like self-monitoring of diet and activity, that enhance the patient's ability to adhere to the reduced calorie diet. Now, many patients will also need weight loss medications. You know, when a patient loses weight, there's a whole host of pathophysiological mechanisms that drive weight regain. And patients have to fight against these mechanisms. You know, hormones like ghrelin that make you eat more go up, and hormones like GLP-1, PYY, CCK that make you eat less go down. Your resting metabolic rate goes down, which favors positive energy balance. So patients got to fight against all these things. Why it's important to recognize the importance of weight loss medications in these patients. They counteract some of these mechanisms that are driving weight regain and help the patient comply to or adhere to a reduced calorie diet. So these are exciting new tools we have. We have the ability to really make a difference, to treat obesity as the disease it is. You know, just as like if you detected a high blood pressure in the office, a high blood sugar, high blood cholesterol, you wouldn't let that go. You'd intervene to the patient's benefit. The same thing is true with obesity. And we really hope our guidelines can provide an evidence-based, rational model of care that healthcare professionals can follow and achieve you know, the best outcomes for their patients with optimal benefit risk and cost of intervention to the patient's benefit.